Hello class, this is Module 3. We will be covering chapters 22, 23, 25, and 26 in this audio lecture. The topics will be panoramic imaging, extraoral imaging, digital imaging, and three-dimensional digital imaging. You will note that as this presentation progresses, the slides may be slightly different than what you have in your PowerPoint handout, and that the information has changed slightly. I am only upgrading this audio lecture to include all the information that I would present during the lecture time. Please note that this information is very important because next Thursday you will have an exam that is on September the 14th, and it will include Module 3 in the exam. It is important that I tell you that we cannot be off track with our schedule as it is very tight. So please review this lecture as many times as necessary to prepare for exam 1. And if you have any questions, please text me or send me an email so I can address your concerns immediately. We must make up all our lab and lecture time. This audio lecture, will satisfy our lecture for tomorrow. However, our lab time will be made up during the finals week, last week of December, most likely on December the 7th, from 8:30 to 12 o'clock. Let's begin with chapters 22 and 23, panoramic imaging and other extraoral imaging. We spoke previously before on panoramic radiography, and I showed you a panoramic film. This is a wide view of both the maxilla and mandibular arches in one single radiograph. Panoramic radiographs are called tomographies. They are rotational panoramic imaging in which the tube head of the X-ray machine travels around the head with the receptor on the opposite side receiving the X-rays. Patients must stand very still and straight in a stationary position, and at times, because of the way this radiograph is conducted, there will be blurred images on each side of the patient. These will later be discussed as ghost images, and I will be pointing them out in the upcoming slides. The purpose for using panoramics is basically for the evaluation of eruption patterns, impacted teeth, growth and development issues. Sometimes we're looking for disease, lesions and conditions, or trauma. What they are not recommended for is carious lesions, because you cannot see details between the interproximal spaces of the images of the teeth. Also, we do not use them for true detection of periodontal disease because you cannot identify the very initial stages of changes in the alveolar crest. We also do not look at them for periapical lesions because of the blurriness that is in the films. We pretty much use periapicals, which give us a nice clear image of the apex of a tooth to evaluate for periapical lesions. The supplemental radiographs for a panoramic X-ray are bite wings or periapicals. Typically, bite wing radiographs vertically placed as opposing to horizontal is preferred, and these bite wing series are the complement or complete a panoramic radiographic series. Periapicals are recommended only when they are specific areas that require more attention. Therefore, there is no standard periapical radiograph that is normally taken, but it would be on a per patient needed basis. The process of taking a panoramic radiograph is demonstrated in this image. You will see that the X-ray source is on the opposite side of the image receptor. So as the radiation is initiated within this X-ray tube head, it is sent to the opposing side, which holds a cassette that has a specially sensitive, photosensitive type of film, and the image then is placed on this opposite side. As the X-rays are conducted, this machine moves around the head, and again on the opposing side, the X-rays are sending radiographs to the receptor, and it is collected on the plate. And there is where you have an overlapping of anatomy, and you will sometimes see what we call ghost images. How these machines work is through rotation centers that are located along the path of how the X-ray head travels around the head. These are pivoting points in the cassette carrier within the X-ray tube. They are located in specific areas, and the more rotation centers that a radiograph machine has, the better the quality of the image. Let's look at the image to the left. You will note that there are, in the first image, there are three tube heads that are traveling around the sketch of the jaw, and you will see that in image A and also in B. Look at the right side and you will note that there is many more of these little tube heads firing around the jaw. These are creating more and more images, therefore there will be more pictures that will be taken to create the panoramic image. These machines are much more expensive, but the quality in the radiograph is much better. The image that is created by the templates of the maxillary and mandibular arches is referred to as the focal trough. This focal trough takes on several natural sizes that are determined by the patient's size. These measurements are designed to either be from front to back or what we call anterior to posterior, which is illustrated by the red arrow. It tends to be narrow in the anterior regions than in the posterior regions, which calibrates the right to side or buccolingual dimensions, which is identified by the green arrow. And then there is an up and down or vertical alignment that is determined by the blue arrow. These focal troughs, again, like I said, are calibrated to the size of patients. Most machines will have up to 4 size selections, and each of these size selections determines the size is in response to the patient size, also has its own particular jaw size line. The other thing that calibrates in the machine when you're selecting the type of focal trough to patient size is the amount of radiation each patient will receive. The focal trough size selection and shape can be determined by, of course, the patient size, and these are measurements that are preset in the machine. Each machine, depending on the quality of the machine, will have a variation of focal trough sizes. The machine in our clinic has 4 focal trough sizes. If you note in the image to the right, you will see 9 focal trough sizes. That machine is quite expensive. As it is now, our digital panoramic machine costs us probably about $10,000. So the quality of the machine is determined by the size selection of the various different focal trough sizes, and it also is determined by the number of rotation centers, which we will talk a little bit more about as we go on. This image identifies the different focal troughs and the rotation centers and how they function. You will see in figure A, the image identifies a particular area of the mouth that it's radiographing, and then you will see the image as it appears in a panoramic. This particular panoramic was created through 3 different rotation centers utilizing that one focal trough. The next slide is an animation of how a panoramic radiograph is created. It will use 7 rotation centers around the one size focal trough, and I'm hoping after you review it you have a much better idea of how these rotation centers are a slit of imaging that is then pieced together to create one complete panoramic radiograph. The exposure controls are determined by the patient size selection, which also determines the size of the focal troughs. Size selection varies among the 4 settings. We have to look at these preset measurements as determined by the manufacturer for the what we call milliamperage, kVp, and time. When we select a patient's size and then it determines the size of the patient's focal trough, it also will calibrate to these specific measurements, the MA, the kVp, and the time needed to create the best exposure. In this image, we're going to take a look at the components of a panoramic X-ray unit. The X-ray tube head is very similar to an X-ray tube head from intraoral radiographs. It does have a culminator that is slightly different than the size of the culminations that we have with regular intraoral radiographs. The openings are usually round, and it also depends on the type of machine as far as the size and power of the machine. The head positioning device, which is identified as B in the image, will hold the head in position and support the chin. It will also place the teeth in what we call a notch block, which will keep the teeth in the proper alignment for the radiograph. It has a head rest and lateral head supports to keep the head from moving. The exposure controls, which are located on the panel on the main support of the machine, is determined by the manufacturer. And once the patient size is selected, it will also set the size of the focal trough and also the amount of radiation that is produced or needed to expose the film. The film is placed into a cassette, and these cassettes also are called intensifying screens. These intensifying screens are slightly different in that they are what exposes the film in the cassette as opposed to direct radiographic X-ray interacting with the film itself. When panoramic radiographs are exposed, the type of radiation that exposes the film is not direct. It is an indirect process which uses intensifying screens within the cassettes. The intensifying screens convert the radiation to light, and the phosphoric material, which is contained within the cassette frame, exposes the film. The process reduces the amount of radiation to the patient. There are 2 types of intensifying screens located within the cassettes. One is calcium tungstate, which emits a blue light. The other one is rare earth, which emits a green light. We prefer the rare earth intensifying screens because they allow for even a lesser amount of radiation to be used, and they're much faster. This image is a cassette that is used in our clinic. You will see how the film is slided into the cassette and it is closed. These come in very different designs. They can be rigid or flexible. They can be curved or straight. They are all light tight, and they are usually marked with an orientation to the right and left side of the patient. There are 2 anatomical dimensions that are used in panoramic radiographs. We look at these planes, the Frankfurt and mid-sagittal, help us orient the patient and the body alignment when they are placed in the X-ray machine. The Frankfurt plane passes through the floor of the orbit of the eye and the external auditory meatus, which is the inner ear. It is parallel to the floor. The mid-sagittal plane divides the body into right and left sides, and that is perpendicular to the floor. This is a diagram of the changes in magnification that occur because of the panoramic imaging. You will see that magnification can be up to 30%, and it occurs either horizontally, vertically, or both when you're exposing a panoramic image. This is unlike the type of image we get with periapical radiographs, where the image is very close to the natural size of the teeth. There are both advantages and disadvantages for taking this type of radiograph. The advantages include what we call field size. This is the total amount of area that is covered when an exposure is made. We have a large area to evaluate, much more so than any other type of film that we take. It is also very simple and easy to accomplish, and it's very patient comfortable, therefore you have a lot of patient cooperation. It has minimal exposure, and it is best used for evaluating impacted teeth, eruption patterns, growth and development, also looking for lesions, disease, and conditions that cannot be seen with either simple periapicals or bite wings. And we also are able to evaluate trauma to the maxillary mandibular jaw lines. There are also disadvantages. The image quality is not as clear as with periapicals, and the focal troughs, which determine the size of the patient, is very limited to just 4 selections of sizes or even a few more depending on how good the machine is. There are areas of distortion and which will appear as ghost images, and we'll talk about that a little bit more. The cost of the equipment is extremely expensive. And then there are things or diagnostic exams that we do that these type of radiographs are not recommended, and that is for carious lesions, decay, periodontal disease, or the use of trying to determine periapicals or periapical lesions when we're looking at conditions located on the apexes of individual teeth. In preparation for placing the patient into the machine, we want to make sure to avoid typical and common errors. Operator preparation would include preparing the panoramic machine by loading the cassette and ensuring that there is film in there. And then you will also have a computer setup if you're using the digital machine. We place plastic sleeves on the bite block. We select the appropriate patient size. And we have correct lead apron that are applied. We do not use a lead apron with a collar on it, the thyroid collar. The patient preparation must be that they remove all head and neck metals, earrings, partials, necklaces, nose earring, if the tongue has been pierced, there maybe be piercing in the tongue. Anything that would radiate metal. Again, it is a lead-free apron, and we then also have to tell the patient that this machine will move around their head, and they may want to try and move away from it as it will brush slightly against their hairline. So we need to inform them that this is a rotating machine, that they must stay very still. We will also instruct them to place their tongue to the palate. They may want to hold their breath for the few seconds that the machine is rotating. So there are a lot of things to prepare them and inform them on, so that way the image comes out as diagnostically nice as we want it. In operator preparation, we want to make sure to load the panoramic film into the cassette, but we must do this only in the dark room. The area must be very light tight. There cannot be any light contamination. The door must be shut. The red light must be facing upward. And we only open the box of film in the dark room, and then we immediately reseal it. If we contaminate this box of film, it will ruin all the other images or all the other patient exposures until we figure out that it was contamination light leak on our x-ray film. We prepare the digital pano by uploading the computer, logging into the computer and getting to the right section. And we cover the bite block with a very small plastic disposable ring, and it's part of the PPE for this equipment. There is very limited PPE for this equipment, so the bite block plastic is probably the only thing of importance. With patient preparation, we want to explain procedures to the patient, place the collar-free lead apron around their shoulders, and removing all head and neck metals and objects, remove all oral appliances, and then you're going to assist the patient into the chin rest and make sure that the they have their teeth properly placed on the bite block. There's a little notch in there that the teeth will be settled into. So they're going to be instructed to stand very tall. If for patients that cannot stand, we do have chairs that you will place the patient in a chair and lower the machine to their level. The back must be extremely straight as possible. The actual position is slightly uncomfortable. We'll discuss the lean that typically has to occur to straighten out the neck. And you're going to ask them to try and hold their breath during the exposure, which is only a few seconds. In patient preparation, we are going to position the mid-sagittal plane perpendicular to the floor and the Frankfurt plane parallel to the floor. There will be lights that will appear on the patient's face that will help you ensure that these planes have been properly aligned. You're going to lower the tube head to the patient's shoulder. The cassette will rest on the patient's shoulder with probably only a ½ inch space between the shoulder and the cassette. It does not sit on the patient's shoulder because therefore as it turns around it will move the patient, but it glides to the top of the shoulder and with just a very little bit of space to travel through. You may place your 2 fingers to ensure that you are within this 1½ inch space. Instruct the patient to place their tongue on the floor of the mouth. This is extremely important. If the tongue is not placed to the floor of the mouth, it will skew the image, and we will discuss the error that occurs and how it will interfere with the diagnostic quality of the film. Keeping the tongue in this position during the entire exposure, you'll be instructing the patient as the machine moves around the head to ensure that this tongue position and the shallow breathing or holding of breath is maintained. They will close their lips tightly around the bite block, and they must be instructed to remain still while the machine rotates around their head. We have 2 types of panoramic machines in our clinic, a film panoramic machine and the digital. These instructions are for the film machine. You will set the exposure factors for the patient of size, making sure to place the selection on P1. P1 will allow you to select a small, medium, large, or extra large size selection. P2 is for magnification, and you will not want to use this setting when exposing a panoramic unless there's a particular reason for wanting to look at the radiograph in that manner. So other settings will be discussed later. You will also only use a lead apron without a thyroid collar, and the lead collars interfere with the capturing of all the mandibular anatomy, therefore they're not used in panoramics. This slide is not in your PowerPoints. I realized as I'm doing this lecture, I needed to include this information. The second machine we have is a digital panoramic machine. There is instructions on the wall how to select the patient size. Please read them carefully for settings and selection. This machine was just introduced to the clinic maybe about a year ago. Therefore, the instructions haven't gotten into these PowerPoints, but they are on the wall for you to learn. When exposing any of the panoramic radiographs, you want to announce quite loudly that you are taking a pano. This informs all people walking through the hallway to avoid this area during this time that they're hearing the high-pitched noise that the machine will make, which lets you know that their radiation is actually being sent to the film. You will press the exposure button the entire time, just as you are doing an intraoral radiograph, and you do not stop pressing the machine because it will stop the radiation exposure until it's made its full rotation. Remove the patient from the machine, remove the lead apron, and hang it up on the wall. Set your patient in your operatory or in a chair while you are waiting to view the film or expose the radiograph. If you're doing the film panoramic, you will complete this in the dark room, and then that's going to take a few minutes, so therefore that may be the best time for you to place your patient back into your operatory. If you are doing a film panoramic, make sure to reload the cassette with new film. We use 2 films as well. We want to expose 2 films at the same time, so that way we have a copy for our records and a copy to go with the patient. And ensure that the film has been labeled on the right side with your name and date actually on the film itself. With digital panos, you don't have to worry about these procedures because they're all automatically done, and you literally print out the image on paper, and you can let that go home, go with the patient, or the image can be sent digitally through email to their dentist. You must avoid patient positioning errors. Therefore, we're going to go through a couple of review of this information. You make sure to review all their objects. It will interfere with the image completely. Do not use a lead apron from the clinic or from where the extraoral machines are located. It has a lead collar on it. Make sure that the correct position of the head has been attended to. The Frankfurt plane for its head alignment must be parallel to the floor. The mid-sagittal plane is perpendicular to the floor. Lips must be closed around the bite block. Tongue must be placed to the floor of the mouth. Anterior teeth must be placed properly in the bite block. And the spine must be straight and erect. I'd like you to compare this slide with the slide that is in your PowerPoint handout. As I noticed, there are a few errors on this slide, which I'm correcting. So please reference this slide and make these corrections on your PowerPoint handouts. The type of radiograph that's taken with panoramics causes ghost images and artifacts to naturally appear. They obscure the diagnostic quality of the information the film offers. When there are removable objects as earrings, nose piercings, etc., not taken off the patient, these objects become major interferences with diagnostic quality. So we want to ensure that there are no earrings, necklaces, hairpins, partial dentures, removable orthodontic appliances, hearing aids, and any type of piercing on the face has been removed from the patient. Let's take a moment to look at this radiograph. Arrow 1 is pointing to an earring that is left on the patient as the radiograph was taken. Arrow 2 is pointing to the ghost image or artifact that is created on the opposing side of the patient because the earring has been left in on the patient during the exposure. You will also notice that there is on the right side of the patient, there is a line going across a white radio opaque line, which is the ghost image of the earring which was left on the patient on the left side. So in this radiographic image, we have truly ghost images on both sides, right and left, but you can't, the right side earring is the one that's most obvious. In this radiograph, we also have two sets of earrings. You can see the right and left earring. And then in the center of the film, we have the ghost image of these earrings. So this gives you a good idea how they will radiograph and interfere with diagnostic quality of a film. This is another radiograph that has earrings left in. And being these are much smaller earrings, you can see the yellow circled outlining the ghost image that has been created from these earrings. I know it's hard to see some of these artifacts because you're just now looking at radiographs, but as time goes on, you will start understanding what appropriate anatomical landmarks are in these films and will easily identify these landmarks later on. But it gives you an idea why we do not want to leave any type of jewelry on a patient. In this image, the patient's glasses were left on, so you can see the impression of how they appear on the radiograph. This image is of upper and lower partial that was left in the mouth during the radiographic exposure. In this radiograph, the red arrow is pointing to a tongue ring that was left in the mouth during an exposure. In this image, we are able to identify the use of a lead apron. The angle of the X-ray machine is about 10 degrees negative. So therefore, you're going to have an upward slope that isn't actually noticeable while taking the panoramic, but it does exist. And any type of lead collar that is left on an apron or used on an apron will cut off some of the anatomical areas that should be exposed in these panoramic images. So this radiopaque cone shape is an artifact created because a lead collar, a thyroid collar, was used with this type of radiograph. This problem can occur even with a regular lead apron without the thyroid collar. If the apron is improperly positioned so far up close to the neckline on the patient's back, it may also block the beam of radiation, resulting in this clear area or white unexposed area on the film. So this image is not just isolated to using the wrong type of lead apron, but also its position across the patient when you're using a non-collared lead apron. Earlier in this lecture, I mentioned the use of Frankfurt and mid-sagittal planes to align the patient's head into the bite block and into the machine. So we're going to go into the details of why keeping these planes in their alignment to the floor is so important. The head positioner is a device that will secure the patient's head to maintain the Frankfurt and mid-sagittal plane. These apparatuses are adjusted as you place the patient into the bite block, and you secure these handles around their head. There are lights that will radiate onto the patient's face, which will help you get the correct Frankfurt plane and mid-sagittal plane to ensure that the head is straight and that the chin is in the right alignment to the floor. There is a chin rest, a forehead rest, lateral head supports, and lights indicating the proper alignment. Pay close attention in this image how the Frankfurt plane, illustrated as FP, creates a line that is a lighted line that is parallel to the floor. It comes across underneath the eye and across the top of the tip of the nose and all the way to the ear. Also, the MSP is a mid-sagittal plane, which splits the patient's face into a right and left half. That again is perpendicular to the floor. In this image, you will note that the teeth are in a notch in the bite stick, which secures the position of the jaw. If for some reason the Frankfurt plane is not parallel to the floor and the chin is tilted slightly upward, we will have what we call a frowning pano. He is unhappy. The line of the chin is too high, causing the smile line to be reversed. The pano looks sad and frowning. The solution is to lower the chin to its normal position and ensure that the patient's head is that the Frankfurt plane of the patient's head is parallel to the floor. I'd like to open up this image so you could get a better idea of how this frown line appears when we're comparing it to a normal, properly placed pano. So the bottom image shows a slight smile. It is not exaggerated. And the upper image shows a more downward placement of the jawline. So you can get an idea that the Frankfurt plane is not in alignment in the first image, but properly aligned in the second. Let's take a look at the Frankfurt plane when it is too low. When it's dipped downward, we have an exaggerated smile line that will appear. We have a happy pano. Again, the Frankfurt plane does not remain parallel to the floor as the patient's position is established in the panoramic machine. The chin is slightly tucked downward into the neck, and then it encourages a happy pano. This, again, is caused because of the angulation of the panoramic machine. It is at a 10-degree negative, which will encourage more of a smile line. So the chin being too low or tipped downward will create an exaggerated smile line, and we will compare the two images or the two placements in the next slide. We can compare the two images and see how the downwardness of the jawline creates a more exaggerated smile than which is normal in a pano. So image 1 demonstrates the slight upwardness, where image 2 gives you more of a natural smile line that is allowed with a pano machine. BN2 is more subtle, and number 1 is a little bit more exaggerated. Depending on the downwardness of the jaw, also depends on the exaggerated smile line that will appear in the image. Let's take a look at changes in the image when we are out of position with our mid-sagittal plane. This is that the head is not centered or straight. If the head is tilted to one side or the other, it will skew the images as far as how the teeth will appear on the radiograph. The teeth closest to the teeth in the focal trough closest or further away from the tube head as it rotates around the face or the head and neck will determine the size of the teeth. In this image, the teeth will appear either smaller or larger depending on the head's tiltness towards the panoramic machine as it travels around. Let's take a look and compare the mispositioning of the mid-sagittal plane in image 1. Look closely to the right side. You will notice that the teeth are quite large when compared to the left side of the panoramic. Look down again on image 2 where the teeth are appropriately sized comparing the right and the left. When the panoramic machine is closest to one side, the teeth will appear very large. When the head is tilted where that part of the jaw is furthest away from the panoramic machine as it rotates around the face, those teeth will become much smaller. Let's take a look at the shape and size of teeth when they are not properly set in the bite block. If the teeth are positioned outside the bite block, creating a distance from where the panoramic machine will come across those anterior teeth, they will appear very fat. Notice the yellow line that I have, the dotted yellow line on the bite bit. You notice the teeth are behind that line. This causes them to be furthest away as the machine rotates across the front of the face, and then the teeth are out of focus and they will become very fat looking. Let's take a look at this slide. It will show you the diagram of how the teeth will look much larger, being outside the bite block, further away from the X-ray machine, and give you an idea of how much wider and obscure and magnified these teeth, anterior teeth, will appear. If the teeth are positioned in front of the notch, they are closer to the X-ray machine. The anterior teeth will appear very narrow and thin and maybe obscured as well. If the teeth are in front of this notch, they are then closer to the film and the X-ray machine, resulting in less magnification. They will appear very narrow and being out of focus from the focal trough, which causes a loss of image quality. Take a look at this diagram as the teeth will appear very skinny, and how the positioning outside the bite block notches is more what we call anterior and closer to the film. Again, the lower image is how the radiograph will appear with the teeth not in proper size and shape. We also have errors when the lips and the tongue are not placed in the proper position. If the lips are not closed tightly around the bite block, they will create a darkened radiolucent shadow obscuring the anterior teeth. If the tongue is not intact or placed firmly against the palate, it also will create a dark radiolucent shadow obscuring the apices of the maxillary teeth onto even the posterior teeth. The solution is to ensure that the patient has their lips tightly pierced around the bite block and that the tongue remains pressed against the palate through the entire exposure. Look closely at this panoramic. The arrows pointing to the tongue not being placed to the palate makes it very obvious that this airspace is exposed. You can also look closely around the anterior teeth in the yellow circle, and you may be able to identify the outline of the lips, as this area will appear more radiolucent. I want to take a moment to look at the tongue position and the palatal glossal airspace that is created when it is not pressed against the palate. We will go into more detail on airspaces in radiographic panoramic images later on in the course. This palatal glossal airspace is this blackened area or radiolucent area that is defined in this image as well as in the diagram. It makes it very difficult to diagnose periapical pathologies when this darkened space obscures the maxillary apices, the teeth of maxilla. Many patients have difficulty complying with the instructions to keep the tongue against the palate during this exposure, and then it ends up making the film non-diagnostic. So be very careful to instruct them and educate them on the importance of maintaining this tongue position. Another important tip in patient positioning is to identify the actual placement of their feet while standing in the panoramic machine. The feet are positioned 6 to 12 inches inward. This will cause the patient to have a slight lean backwards. What this allows is that the head and neck can then be properly aligned to be very erect and straight. The body leans slightly backward allows chin placement to be supported in the headrest or into the bite block, and then the patient must grasp the handles that are on the machine to secure themselves in this position. Not all patients, especially the elderly, will be able to maintain this, but it is something to try and think about and encourage, so that way we can get head and neck alignment properly positioned. When we do not place the patients in the machine correctly and create this lean, what we may end up with is that the cervical spine will appear into the radiograph. This slumping or slouching of the shoulders obscures the image and again creates an undiagnostic or a poor quality radiograph. The curvature of the spine is more advanced or aggravated or exaggerated with adults. So this slight lean inward to the machine, causing them to support themselves just a bit, helps to erect the head and neck properly to avoid the cervical spine appearing in radiographs. Let's take a look and compare when the spinal cord is too obvious in a panoramic image. Number one shows a properly exposed panoramic, and number two shows the slouching of the head and neck forward, causing more of the image to appear, or the spine to appear, on the radiograph. Let's take a moment to review these two panoramic radiographs. Number one obviously shows some serious movement and how totally useless this film is for diagnostic quality compared to number two. I'd like to review some of the common exposure errors. One would be the focal trough size selection. This refers to the type of patient size you have and making sure that you use the proper size to determine the focal trough for that patient in relation to their jaw. Lips are left open and not closely placed on the bite block. The tongue is not compressed to the palate. The patient may be moving during exposure. The cassette is not properly placed close to the shoulders and therefore will cut off the chin. The machine is left too high or too low. Exposure is interrupted either electrically or by operator error because the button is not compressed or held down the entire time of exposure. Make sure to select the proper focal trough. We have 4 size selections. With the film pano machine, you select P1. The image is set for the digital pano, and the instructions are in the room that the digital pano machine is taken. The sizes are for a small child, an adolescent, a young adult, and a large adult. The problem with choosing the wrong focal trough will affect your image diagnostic quality. Image 1, you will note that is quite large. The occlusal planes of the teeth, the actual teeth, are taking up the entire image. There's no anatomy on either side of the molars. In image 2, you'll note there is so much head and neck anatomy that we've got a large area of the cervical spine in the image, illustrating a very tiny mouth, and this size selection was too large for the patient. So be very careful in choosing the appropriate size selection, because if it is too small, you will only have the teeth appearing and no anatomy. If the size selection is too large, the image mouth will appear very small, with a lot of head and neck and cervical spine appearing in the image. If the cassette is not lowered properly to 1.5 to 2 inches gap between the shoulder and the cassette, you will cut off the chin of the panoramic image and therefore eliminate any of that diagnostic quality in the film. I'd like to make you aware that there has been a slight change to the information on your PowerPoint handout than is in this slide. I have highlighted the change in yellow. Please make note and correct your PowerPoint handouts. If the cassette is positioned too low, where it's sitting almost directly on the shoulder, or if the patient has a very long neckline, you will end up losing diagnostic images and anatomical landmarks of the sinus area and in the nasal cavity. So this is what the image would appear to be like if it is set way too low and you have entirely too much information being shown below the chin and missing areas of diagnostic landmarks above the palatal areas. I'd like to again repeat on the problem with patient movement and the blurriness that does occur. Compare image 1 and image 2. Image 1, there has been movement, and you can see the whole quality of the radiograph is undiagnostic as compared to image 2. This is a new error that I'm just introducing in this slide. If there is a problem with an interruption in radiation or electricity, that particular rotation center will not fire, and this area of the image will not appear. So this typically shows as a blank or clear area of unexposed film, and is typically due to either the button being released and pressed again during the radiograph exposure. There is typically just some type of interruption in the radiation being continuously sent to the film throughout the exposure. Let's take a moment to test ourselves to see if we can identify the exposure errors and the corrections for them. Let's watch this short 3-minute video, and it'll go through the details of loading a patient into the machine and exposing a panoramic radiograph.
When you're doing panoramic radiographs, you may be wondering why you can't use an intraoral apron. The intraoral apron has a thyroid collar and an open back. When the panoramic machine goes around the patient, it comes at a 15 degrees upward angle and would catch the thyroid collar, and it would cover up some of the information that we need, especially on the apices of the teeth. That's why we have a specially made apron for the pan. The pan apron velcros in the front and comes long in the back. It covers the spine up. Now you can see that there is an area that is dipped below, and that is an area that we want to uncover because, as I said before, the pan unit is coming this way, and if it were here, we get, even with this apron, we'd get something that's called the shark fin. Before you take the panoramic x-ray, you want to make sure that you take off glasses, earrings, necklace, and any partials or dentures that the patient may have. Otherwise, you may get an image that has ghost images of the earrings. If you don't take out a partial, this is what a partial would look like if it was left in while you take the pan. We want to bring the patient in. You want to make sure that the patient is biting on this bite block. If she's not biting on this bite stick, what will happen is the teeth will be overlapped, and I do have an image of that to show you now. One other thing that you have to make sure that you have is the patient is going to be straight. If this side or the other side is too close, this side is going to be closer to the x-ray tube when it comes around, and it's going to be very magnified, as you can see in this image. Also, what you want to make sure is that you're in the focal trough. The focal trough is the area of interest of where the whole arch is. If it's too far forward or too far backwards, it's going to be out of the focal trough, and you can miss some very important things. You can see that we have an image of it out of the focal trough, and then we have it in the focal trough where we see that you can see a cyst with a tooth that would have been missed as a diagnosis if we left the first one. One of the most common problems that we see is that we see that the chin is not in the correct position. If the chin is too far up, the back of the head is going to be this way. It's going to have a line that usually will come over the top of the anterior apices, and also the smile line is very flat. We want to make sure that the chin is down, and you can see the infraorbital line. This line to the ear is parallel with the floor, and this is a picture of what the perfect image of a pan should look like. In wrapping up, it's important to use the correct apron, but also it's important to check your aprons on a monthly basis to make sure that your aprons aren't cracked or have any pinholes in it. What happens is that when you have a crack or a tear, the lead is being exposed to the patient, and you do want to replace the apron so that your patients can be safe. You can eliminate these cracks by hanging up the aprons properly rather than folding them in half and putting them on a chair.
There are other various types of extraoral imaging. One of the most advanced ones is a cone beam computer topography. This is actually a 3D image. It utilizes a narrow cone beam radiation scan of the maxilla and mandible all at one time. There's quite a little bit amount of radiation, less than what a panoramic film would provide for the patient, and you can see the image is quite detailed. We also have ultrasound, which echoes the body parts and images that become plotted on the screen to measure depth. The MRI is a magnetic resonance imaging. It uses powerful magnetic fields, radio frequency, and pulses, which are this information is then sent to a computer to create the image. We will move on now and discuss Chapter 25, Digital Imaging. I'd like to begin this chapter with a short video that will go into a little detail on digital radiography for you.
The computer era has brought us a dental technology called digital radiography. With this technology, we use computerized equipment and software to capture X-ray images of your mouth and teeth by exposing a small sensor or plate that feeds the image into a computer. Digital radiography has many advantages over traditional film X-rays. It's faster and safer, and the X-ray images can be enhanced and electronically stored and retrieved. Taking digital X-rays is faster because the sensor is merely moved from tooth to tooth, and your X-ray can be seen on a computer monitor just moments after exposure. There's no waiting for chemical development, as with film packets. The lack of chemicals also makes digital X-rays safer for the environment. Digital radiography is safe for you too. Because the unit is so sensitive, the amount of X-ray radiation is up to 80% less than with conventional X-rays. Digital X-ray technology enables more efficient diagnosis and treatment because it provides a large, easy-to-see image, and it allows us to make adjustments and see details in the X-ray images. The digital X-rays can then become part of your dental record and be easily emailed to specialists and insurance companies. With digital radiography, we can offer you faster and safer diagnosis and dental treatment.
Digital radiography has become very popular in dentistry. Over 30% and probably even a larger percentage of dentists are now using digital imaging. Many companies and types of software are available, as are their intraoral sensors, which digitize the image and convert it into an analog form, which are then represented as a digital traditional film on the computer. Radiation exposure, depending on the quality of the sensor, can be reduced as much as 90%. Within our clinic, the radiation exposure is reduced by 50%. And even though we do not have the best, most high quality sensors, those sensors ran between $5,000 and $8,000 a piece. I know I've mentioned it in class before that when using these digital sensors, we must use the utmost care to protect them from hitting the floor or falling and hitting the counters, because once a digital sensor is broken, it goes out for repair and can be out for the entire length of the course. This will affect all of us in that each student then will have less time on the X-ray machine to complete their requirements. So let's take very good care in protecting these digital sensors. The specialized equipment that is needed is the intraoral sensor and the computer, and of course an X-ray source. Standard equipment with the X-ray machine doesn't require any special change other than to reduce the exposure time. The sensor is much more sensitive than regular film. Exposure time is reduced by 50 to 80% when compared to F-speed film. The images are binary computer languages of numeric and discrete zeros and ones. There is this spatial distribution of the pixels, which gives us the difference in shades of gray, which kind of works like the halide crystals within the emulsion of dental film and gives us the image that we can use for diagnostic purposes. There are two types of sensors that are used with digital radiography. The direct digital imaging is what we have in the clinic at this time, where the sensor is directly connected to the computer. The other is the indirect digital imaging, which uses these very rigid phosphoric plates, and the plates are exposed and placed into a particular device, and then it's transferred into the computer. We used to have this system in our clinic, but we no longer use it because the direct digital imaging is much more convenient and easier to use. I'm introducing the indirect digital imaging because you may come across these phosphoric plates in private practice. They're very inexpensive and extremely effective. Of course, they create more operator time with organizing the images as they are projected into the computer software. But other than that, they are a very, very well established digital imaging program. This slide gives you an idea of the difference between using a digital sensor, which is wired and also can be wireless to the computer, and then how the phosphoric plate compares. The phosphoric plate is literally like the size of a number size 2 film, but it is not rigid, it does not bend, and can be very uncomfortable for patients. These diagrams for digital images show the normal visual on A and B. Figure 12 gives you the opposing or negative of the digital image, and it actually shows the reverse of what black and white or radiolucent and radiopaque images will appear if the negative option is selected. We don't work off the negative option, but it is very good when you're trying to look for particular anatomical landmarks or discrepancies in the film, lesions, things of concern. When exposing indirect digital imaging using the phosphoric plates, these phosphoric plates are then energized by the radiation, and they're put into this digital scanner, which then processes the image and sends the image directly to a computer program where it's arranged and placed in a full mount series type of mount. The one great thing about these indirect phosphoric plates is that they can be used over and over and over. You can see in this image that one particular plate has been exposed 130 times, and there's very little change or hardly any noticeable diagnostic changes with this phosphoric plate. They're very strong. They resist a lot of scratching. So they have a very good long use in dentistry, and like I say, they're very inexpensive when the software program is purchased. I like to go over some of the advantages and disadvantages of using digital imaging and comparing it to traditional intraoral film exposures. There is a lot of advantages. One has to do with the instant image we have. There is a superior grade scale resolution between film and digital. We also reduce patient exposure to radiation. There is a lower long-term equipment and film cost with using digital, but the initial startup is quite expensive. It eliminates the space and the chemicals for a dark room. It increases the efficiency and the consistency of image quality. It enhances the ability for diagnostic imaging because the image can be enlarged to view. It serves as an effective patient education tool because you can increase the image and show it on a monitor to your patients. It is also used with remote consultation. The ability to send these images via the internet or digitally to another office, or to be consulted or reviewed by another dentist off-site is a definite added benefit to digital imaging. It improves disease detection and monitoring because of all these other advantages. And it turns a 2D image into a possible 3D image. When looking at the disadvantages, it has a very high initial setup cost. The sensor life, because they're so fragile and delicate, is not as long as we'd like. The size of the sensor is also a disadvantage. It's thicker and requires more space in the mouth. Its margins tend to make the image much smaller. We don't cover enough area as we would with a size 2 film. The cord on the sensor can get in the way and also appear in the image. Sometimes the technology changes and advancements quickly make the sensors obsolete or not as good quality as the newer ones coming out. Therefore, there's additional cost to maintain higher standards with digital imaging. There is an infection control issue with these. The apparatuses that you use to hold the image can be sterilized, but the digital sensor itself is just white clean. We do cover it with a plastic covering to protect it from saliva and blood contamination. But then we're not sure as to the true sanitation that is actually able to achieve. There is a loss of record keeping. If the system malfunctions, we may lose our images and not regain them. There is also legal issues with digital imaging. Someone can actually get into the films or into the image on the sensor on the computer and change the pixels to eliminate or cover up any type of lesion that may have been overlooked in an exam, in a consultation. Software compatibility is an issue when the images are sent from one computer to another. So these, though good and wonderful for dentistry, do have advantages and disadvantages that we must be aware of. This is the last chapter we will cover in this audio lecture, three-dimensional digital imaging. Cone beam CT scans utilize 3D imaging. They view the body in 3 planes: axial, coronal, and sagittal. This type of imaging is used in dentistry mostly for oral surgery, and if an office is very advanced, it will have a cone beam for implant settings. The axial or the transverse takes the body in a horizontal plane and divides the body into superior and inferior sides. The coronal part divides the body vertically into planes from an anterior-posterior position. And the sagittal creates the vertical plane which divides the body into right and left sides. So take a moment to view the image and the types of sagittal planes that are used to create a cone beam CT scan image. There are advantages and disadvantages to cone beam as well as any other radiographic exposure technique. The advantages are that it uses a lower radiation exposure setting, and the scan is done in a very brief time frame. Anatomically, the image is extremely correct and accurate. That is why it is used for surgical procedures, and the image is easily transported or stored and used at different locations or between different doctors viewing the cone beam. The disadvantages is that because it is so high resolution and detail, patient movement can really interfere with the quality of the image. Artifacts interfere also with the diagnostic quality. It is extremely expensive, and it requires a lot of training to interpret the image, so therefore there is a learning curve and a training curve that requires more additional education on the operators that are viewing these films. I'd like to take a moment and let you see this little video. It shows the progression of how these CT cone beams relate to actual facial representation. This is a lengthy 7-minute video that will go into the use of the XCP RIN when using the digital sensors to expose radiographs.
The XCP-DS system is a universal autoclavable holder, and it works well with all the digital sensors in the market. An adjustable clip uses a silicone band to keep tension on your sensor as you're using it and working with it. The size 1 sensors, 1.5 DEXs, and any size 2 sensors work and fit well with the digital fit. If you are using both a size 1 and a size 2 sensor for your full mouth series, this system makes it easier as you can use the same bite block for each sensor. Before using this system, load your sensor into a relaxed fit sensor cover. Then press the edge of the sensor against the clip, lift it up, and pop the sensor in. The fit bite blocks are actually designed to work with a single color arm system or the 3-in-1 Aura system that is also designed by RIN. If you notice, we have 3 different color codes for the 3 different areas of the mouth. The red will be for your bite wings, the blue piece will be for your anterior PAs, and the yellow will be for your posterior PAs. What I'm going to show you are some of the challenging areas using any type of digital placement, but I'll be using the fit. Sliding the fit in to the bite wing, and take your ring system. Notice it's red, so you're going to use the red prongs on the bar. Attach that and slide your ring according to the same color. So you're going to use the red. Slide this in. Always look through the circle to make sure everything is in place and that you can see your sensor right in the middle. Placing this, it's best to put the film actually, or the sensor, closer to the middle of the mouth. Track the cheek, slide it way back there, and have the patient close and bite. Open. By allowing the sensor to be more towards the middle of the mouth, allows the patient to be able to actually reach down and bite right to the bite block and have no separation between the teeth. Usually bite wings are pretty easy. So the two on one side and then the molar and premolar on the other side, and you're good to go. Next step we'll do is the anterior PAs. You're going to take your blue bite block piece, use the blue prong, slide it into the bite block, attach your sensor. Now the last thing you want to do is attach your ring, again using the blue, which matches the blue, and you're going to slide that right under the bar. Also, when you're doing that, always double check again, make sure through the middle of the circle you can see that the sensor is right in the middle, so you have this put together correctly. This is for the anteriors now. So what you want to do is make sure you place the actual base of the sensor deep in the mouth to accommodate the whole bite block. Right, so as she closes, her teeth are on the bite block, and this is correct. What you want to do now is bring your cone around and actually follow the bar position with your cone, and you'll get the correct vertical tube angle. Open. You'll just need to reverse it actually to do the lower two. You're going to take this base, put it between the arch as far back as you can so that it fits, roll the bar up, and then have her gently bite. Again, slide this up, bring your cone in, and follow the direction of the bar with your cone. Open. Notice on the fit system here, we do have a bite block that's a little thicker than normal. This is great when you're doing the anteriors because you can eliminate having to use a cotton roll. The last area I'd like to show you is the posterior PAs. Select your yellow, which is for the posteriors. Use the yellow prong, slide the prongs into the bite block. Now as you attach your sensor, make sure that the wire is going the same direction as your bar. Do not place it in this way, but this way. So just slide it up, attach it this way, wire sensor. The ring system, use the yellow because it's color-coded again. Slide the yellow piece onto the bar. Always double check again to see that it's right smack in the middle so you're not going to cone cut anything off. Now the way I have this put together, I can actually do her upper molar. So when you slide it in, make sure you're sliding it in that this instrument looks like a little V here. Retract the cheek with your forefinger. Really make a lot of room for the sensor because it is a little bulky. Stretch the cheek out so you are putting that bite block way back into the pocket. Have her gently close, and you're ready for your molar. Open. The way this is put together, you can actually do the opposite quadrant right away. So what I'm going to show you is how to place it back on a lower molar. I usually hold this with my left hand and use my right index finger. This piece here must go within the cheek, so make sure you really make a nice pocket. The sensor itself has to slide right next to the teeth. So you got to stretch that cheek out, slide that sensor way back so that you're back by the molars holding the cheek. Once you get it in there, have the patient close, let go. Now you can bring your cone in, following the bar. Open. So you're going to do that molar, premolar, and then the molar and premolar on the lower left. Those two quadrants are done. Now you have the final two on the upper right and two on the lower left. To do that, though, you have to change this position the way that this is put together. I suggest first pull this bar off and put it actually onto the other side of the bite block. Also, you notice my wire is coming up in this direction, bar that way. So again, you're going to just slide this off and turn that also. So now you can see the wire bar. Last thing you have to do, though, is make sure that the sensor is actually positioned right in the middle, and it is not. So last thing, and now you're good to go. Now you're ready to go to do the upper right and the lower left. So this is using the fit system with the Oral 3-in-1 arm and ring. It's very easy to use, it's universal, fits any type of sensor and any size sensor.
So in our lab, we're going to immediately start moving on to using digital imaging, and you're going to love it. The images are going to immediately appear on your desktop monitors and computer screens. There will be no going back and forth to the dark room to expose your radiographs. If you don't like an image, you're going to hit the back button and repeat it. The radiation settings must be reduced to at least half of what the film exposure setting is. And once you take an image, it's automatically saved to the computer. You don't have to click any special button. Just know that if you do not like the film, you must back up and hit the back button to repeat it. And once you repeat the film, it automatically will advance to the next image. So always watch the highlighted yellow T, because that is going to tell you the next image that will be taken. All these instructions are in your tutorial in your lab workbook. If you have any questions, please contact your lab instructor or send me an email. Just like to review the schedule for next week. We will have exam 1. Typically we'll start about 1 o'clock, give you a few more minutes to study and relax after lab that morning. If you have any questions, I like to open up the discussion for questions about the exam anytime during lab that day or right before the exam. I'm open to any type of questions that you may have, so that way your performance is the best possible. Please jot down the slide number and any questions you have and send them to me via email. I will then post your answer to most likely the announcement page of your lecture, and because others may have the same question as well. So check it frequently. After you have sent me a question, I will be responding as quickly as possible. Thank you.